Hi, Dr. Centeno, and thanks for joining us today. Got an interesting topic. Basically, going to talk today about imaging measurements that qualify a patient for CCI. And really, this lecture is important because I get probably about 1 in 4 to 1 in 3 patients where I'll do a telemedicine. Usually a surgeon or someone else has told them that they have craniocervical instability. So we go through the imaging. It doesn't meet my criteria for CCI. And then the patient is confused, obviously. And so I wanted a presentation I could point those patients back to say, what does it take in my mind to be diagnosed with CCI? And at the same time, give patients an opportunity to ask questions about all of this. So we'll do the standard deal where we do a small lecture, and then I'll take questions. This lecture is a little bit more complex than most because I'm covering lots of different information, lots of different types of CCI, lots of different measurements. But I think it's important because it's really critical that patients understand what's out there, right? When they're told that they have craniocervical instability, there should be credibility to that measurement on an image. So anyway, that's what we'll talk about today. Again, if you're just joining us, we're going to be talking about what imaging metrics determine CCI in my book, simply because I get a lot of patients who have been told they have CCI. And then I look at all the different measurements, we review it on a telemedicine, and it doesn't really seem to me that their measurements actually qualify them as having craniocervical instability. So as you might imagine, they're confused, they're not happy, etc. So let's get into this. And after this, I'll take questions, and we will go from there. Here, let me share my screen. And okay, so what imaging measurements qualify a patient for CCI? And this is an update because I've talked about this a few different times before, but haven't really talked about it as one topic for probably about 2 years or so. So first, we're discussing subfailure craniocervical instability here, not frank subluxation or dislocation that requires emergency surgery. And that's an important thing to understand, meaning that we're talking about the vast majority of CCI patients that are out there. They've got some laxity in the upper neck ligaments that's causing big symptoms. And then they are determined to have craniocervical instability based on one of these measurements. Very different from a patient who gets a massive trauma, shows up to the emergency room with their head falling off, quite literally, and gets emergency surgery. So this particular situation happens quite a bit. A patient is seen by Dr. X and they told they have CCI and need surgery or need something. The measurements used are not based on any known study. They're either Dr. X's own misinterpretation of what's out there, or they're not really based in any hard science. And when I tell them later that they really don't have CCI based on what I can see, the patient is upset, floored, mad, confused that they don't meet my criteria for CCI. So I wanted to go through this a little bit. So let's go over all of the CCI criteria that I use, which is based on what's published to date. So first, instability is a movement-based concept. So it generally can't be diagnosed on static imaging, hence the change in signal on static MRI in individual upper neck ligaments like transverse, alar is all interesting. And it certainly may help me decide to treat one structure over another, but it doesn't tick the box of qualifying somebody with craniocervical instability. Another one I get a lot is, well, here's a CBCT from my chiropractor. And again, CBCT may be very useful for looking at vectors and upper cervical adjusting, but it's not a movement-based study, so it doesn't tick the box as you either have or don't have CCI based on your CBCT. So an imaging report from Dr. X showing that you have an alar transverse or other ligament injury based on how that ligament appeared on the MRI image is almost never good enough to meet my criteria for CCI. And this really, I think, confuses a lot of patients. They'll come in, they're like, well, I got my imaging report from Dr. X and it says here that my alar ligament is injured or damaged. And I look at that and I say, okay, well, that's interesting, but we're going to have to see how your alar ligament functions on movement-based imaging before I can make the determination that you have CCI. So let's review some of the more common images, movement-based images that I do see. Rotational CT or MRI is certainly one. And then we've got the different measurements on upright flexion extension MRI, CXA, translational BAI, translational BDI, grab oaks, etc. Then we have much more commonly seen now, especially for European patients, is an analysis of their 3D CT scan. And then we've got DMX looking at ADI and C1, C2 overhang. So rotational CT or MRI, this is probably the one that I see is the most, I don't want to say abused, but is the most misunderstood. For some reason, which I'm having a hard time understanding, someone took a statement out of a single paper by Goel et al., Goel of the Goel and Harms technique, which is an upper cervical fusion technique, so a surgeon. And he had written in this one paper that instability was determined as greater than 45 degrees of rotation between C1 and C2. So this is a situation where the patient goes into the scanner, they turn their head, and then the pictures are taken, whether it's CT or MRI, and then the radiologist measures, as I've done here, the rotation of C1 and C2, subtracts one from the other, and gets a value. And again, this value of 45 degrees or greater than 45 degrees is used, but it's not validated near as I can tell. It seems to have been pulled out of thin air. And the actual measurement is 56 degrees in a paper by Dvorak, where he actually did look at normals and injured people. And so the bizarre thing about this measurement is that 99% of the time, when patients are told they have craniocervical instability based on excessive C1, C2 rotation on a rotational CT or MRI, I look at that and it's, let's say, 46 degrees, 47 degrees, 48 degrees. All of that is less than 56 degrees, so all of that is normal. And I can't tell you how that blows people's minds, because they've got a surgeon willing to operate on them based on a C1, C2 rotational value of 46 degrees. Well, heck, the measurement accuracy here is probably 3 or 4 degrees. So if you've got a measurement of 46 degrees, it might really be 43, it might really be 44. If we get 100 doctors to measure it, we'll probably get values between like 44 and 48 degrees. So it's just realize that you have to have a lot of rotation between C1 and C2 based on the existing research to be unstable. And 99% of the people that are told they are unstable based on rotational CT or MRI don't meet that criteria. Then we get into the flexion extension, MRI measurements, CXA, translational BAI, translational BDI, grab oaks. Bottom line here is these are all measurements of how the skull is moving relative to the spine. In this case, the T means translational, or movement between flexion and extension. Now, the CXA is the angle of forward rotation of the skull, whereas the BAI and Grab Oaks are more measures of the skull sliding, and the BDI measures vertical instability. Now, the best paper we have on this was just published last year. It's a paper by Nicholson et al. It only included basically MRIs of people who they know didn't have craniocervical instability, so they're being imaged for something else. So it's not the best study in the world. It would have been better to see a lot of normals and a lot of people with CCI and maybe that third population that they measured thrown in. But it's no slouch either, meaning it does give us an idea of what these values should be. So long story short is I use for CXA, a lot of folks will use less than 135 degrees. The problem is if you use that based on Nicholson et al., about 1 in 10 patients is going to be classified as having a problem who doesn't have a problem, who just has a normal measurement. So I use the stricter interpretation of less than 128 degrees based on looking at the data from that paper as being positive for CXA. Grab Oaks, a lot of people use 9 millimeters. That's the degree to which the DENS goes backwards. But if you use 9 millimeters, again, about 1 in 10 to 1 in around 7 people will be false positives, meaning that you will falsely identify someone as having a problem who doesn't really have a problem and otherwise has a normal measurement. So I tend to like to use now something between 9 and 10, trending towards 10, which eliminates that concept of a false positive. Translational BDI, which is the vertical instability between flexion and extension, there is no published data on it I can find. If you know of some, let me know, because I can't find any. So that's sort of anyone's guess as to what's normal there. Translational BAI, that's the degree of skull sliding between flexion and extension. I've used 4 millimeters like Henderson, meaning as the cutoff, but there's a significant false positive right there, and it's probably not possible using Nicholson to determine what that false positive rate is, because they didn't really look at translational BAI. They just told you what the values were in flexion and extension. So realize that most patients are told they have pathologic CXA of when it's less than 135, but there's again about a 1 in 10 failure of that measurement rate, meaning about 1 in 10 of those people probably have no issues at all, and they're being told they have problems. And again, Grab Oaks cutoff is usually considered to be 9. But some people have told me their Grab Oaks are abnormal if it's greater than 7. The error rate at 9 is up to 14%. I would imagine at 7, it's got to be 1 in 3 or so. So be very careful with that measurement. Again, we have no reported data on normal and abnormal metrics for translational BDI. And we have limited data on translational BAI. A really popular one I see now is analysis of CD or CT scanning that are 3D. So these are 3D CT scans, and a lot of Europeans get this, but I can find no credible scientific information on what's normal and abnormal and what's likely CCI on CT or on 3D CT scans. So I've seen these analyses. They're very pretty to look at. But the bottom line is we don't have a lot of information here to sink our teeth into as to what really is abnormal and what's not. And again, realize this whole concept is what will we find if we take 100 people off the street right now versus what will we find if we take 100 CCI patients. And as near as I can tell, that is not available for 3D CT. And then finally, DMX. This is based on the Katz and Freeman paper. C1, C2 lateral overhang of greater than 4 millimeters is what I use with asymmetrical position of the dens and the atlas. There's some analysis to be done as to whether it's 3 or 4. 4 has the fewest false positives. And I use an ADI greater than 3 that gets significantly larger with flexion. And that's an important part. I've seen ADIs called when they are 2.5, 3 millimeters, but they're not changing from flexion to extension. So that basically means that there's probably not an issue there with the transverse ligament. So in summary, my measurement cutoffs for CCI are stricter than most surgeons. The goal is to maximize the likelihood that the observed symptoms are being caused by CCI. That maximizes the treatment results for PICL. So again, I'm a little stricter about this stuff because it's very important to me that I'm treating someone who has symptoms that are being generated by CCI. And as my patients know, I will tell you, I'll be the first to tell you if I'm not sure that your symptoms are being generated by CCI, because I'm very honest about that stuff. And I think that's the way this should be, right? I think anyone offering care in this area should be very honest as to what metrics they're using, why they're using those metrics. And then obviously the goal should be to maximize the outcomes of treating this patient population by trying to minimize the false positives, meaning patients who have what appears to be an abnormal measurement, but that abnormal measurement could be found in anyone walking around with no problems. So let's take some questions here, see what we got. Okay, looks like we've got a bunch of questions, so let's get those going. Franco, what works best to treat laxity of the facet capsule, 0112, dextrose prolotherapy, PRP, or stem cells? There usually isn't a need to treat the facet capsules of C1, C2, so that's a little bit of a misnomer. That's a terminology used by prolotherapists who don't have the expertise necessary to inject the actual ligaments that mostly stabilize C1, C2. So the answer to the question would be that if we're talking about any ligament, stem cells greater than PRP, greater than dextrose prolotherapy. But when it comes to, quote, capsular laxity, that's a little bit of a made-up term by prolotherapists who don't have the expertise to inject the deep internal ligaments that are stabilizing. Franco, what are the Regenix options in Europe to treat upper cervical instability? What exactly would be treated in Europe? Facet capsules or joints? So again, when it comes to injecting C0, C1, C1, C2, that's something you need to come to Colorado for. That's because there is no site outside of Colorado that has extensive experience in injecting those upper cervical joints. And you need to be able to precisely inject those upper cervical joints if you're going to try to inject facet capsules. Franco, is it okay to do dextrose prolotherapy after a stem cell treatment for laxity of the cervical capsules? Should I wait after a stem cell treatment with prolotherapy? If yes, how long? Franco, if what you mean by stem cell treatment is bone marrow concentrate, then yes, you've definitely got to wait quite some time because prolotherapy works by killing the local cells that it touches, and that's a chemical debridement. Now, usually that's a net positive, but if you've got stem cells on the ground there that are trying to do their thing, doing prolotherapy after those stem cells, really until after the ligament is fully mature, which is 4 to 6 months, can potentially kill those cells you just added. Simo, what is your opinion on cross-linked HA in PRP? Is it okay to take anti-inflammatory herbal medicine during PRP treatment? I think PRP plus HA, there's enough good evidence now that for joints, like knee joints, it seems to improve the outcomes. So I think that's the good news. As far as taking anti-inflammatories, much would depend on which anti-inflammatories we're talking about and how they work. Franco, for some areas, knees, you first perform a pre-injection with dextrose, a few days later stem cells, and then a few days later a post-injection with PRP. We're not using this protocol in the neck because it's a risk-benefit calculus. So if we were to do that for, let's say, facet joints in the neck, it might be helpful, but we would also, those are higher risk procedures than a knee joint injection, because if something goes wrong in a cervical facet injection, and to do that properly, you need X-ray guidance, contrast, if you're injecting the upper cervical spine, digital subtraction angiography, etc. So it doesn't really make sense to go into the same joint 3 successive times in 1 week in the neck from a risk-benefit standpoint. Bo, how far are you currently booked out for scheduling? Also, how far booked out will it be to schedule for the procedures when you come back in mid-October? You know, Bo, it's a good question. I don't really know the answer to that one. I would imagine that I'm pretty booked between now and the time I leave September 1st. And I would imagine that I'm probably starting to get booked up for the month of October. That's probably the best I could tell you, but don't hold me to that because I don't really track the schedule like that. Light Hope, is it contraindicated to take muscle relaxers post PICL? Probably not the best idea. Listen, if you were taking them pre-PICL and they were helpful for you, then I'd probably take them post-PICL. Many CCI patients find that muscle relaxers, since it relaxes the muscles and they need that muscular tightness, find that muscle relaxers actually make things a little bit worse. But if they were making things better, then you might want to just continue it or take them again for a week or two as you're trying to assess apples to apples comparison from before and after the procedure to see if you've improved. Bo, it's been about 13 months since my telemedicine appointment. Will be scheduling my appointment soon. Can I still use that? Yeah, that's probably pretty reasonable, assuming nothing dramatic has changed in that time interval, meaning that you wouldn't want to have, let's say, you know, my symptoms got 50% worse and I've got new symptoms here and there. That might require some new imaging and a new analysis, but assuming everything's pretty much the same, that's probably fine. But if I were to receive Procan injections for temporary relief, how long should I stop that before PICL? Yeah, Bo, a lot depends on what we're talking about. Usually Procan injections are trigger point injections, and those are done in the muscles. There's going to be some toxicity there. So I would probably put at least a week or two between a Procan injection and something like a PICL. Tasha, I can't find anyone to actually find what is wrong with me. I'm losing my mind. I'm miserable. It feels like there's tension in my spinal cord, crunching my skull neck, clicking when I turn. Yeah, Tasha, so that's something that we can certainly try to help with during a telemedicine evaluation. A telemedicine evaluation would include looking at all your different imaging, looking at your history, looking at your response to treatments, having you fill out a very long questionnaire about all of those different things, and then trying to generate an analysis of the likelihood that you have X or not. In this case, sounds like, you know, a likelihood of whether or not you have craniocervical instability or not. Sonia, high depression syndrome about 7 weeks post-PICL. I know that I have many months of healing ahead of me. I have constant neuralgia and pressure in my head, which were my symptoms prior. But my question is, would it be beneficial to come down for nerve testing and higher dissection prior to my 4-month follow-up, or just evaluate the situation at that time and go from there? You know, either one, Sonia, meaning it sounds like what you're asking is, should there be a greater evaluation of trying to see if some of the occipital nerves might need to be additionally treated to reduce the pressure in the head. And I would say that most patients between the time where you are and 4 months will report that that gets better, but there'll be some patients not. So That's a hard one for me to answer. In your particular case, will it be better for you to come down or not? Always happy to take a look to see if there's more that can be done before that 4-month mark. Virginia, submitted advanced by Sherry Scott. Is there anyone in Florida that you could recommend to rule out other upper cervical issues before we get a DMX? Yeah, no one in Florida that I would count as an expert in upper cervical instability. No. I think what you're asking, are you asking about imaging, doctors? Maybe clarify that as well, because I want to make sure I'm answering your question accurately. Jessica, is it wise to continue seeking surgical intervention from neurosurgeons that I based my own research and symptoms I feel in effusion, even though my scans are normal? I don't know what you're asking here, Jessica. Maybe rephrase that, because I'm having a hard time understanding how best to answer that question. It's been advanced by Harry Winston. Are there any medications or supplements we should avoid for hoping to do a telemedicine visit with you for a CCI diagnosis? No, not for a diagnosis, no. Jessica, will C2 to C7 injections in the back of my neck help with any stability at all? Yeah, Jessica, so there's only one type of the 8 different types of CCI that is helped with those sorts of posterior injections. That's a type 3A, which would be instability of C2 on C3 inflection. And so if you've got that type and only that type, then those sorts of injections can be very helpful, treating the posterior supraspinous, interspinous ligaments. If you don't have that type, then they're not going to be all that helpful. Era, hello, Centeno. You've covered this before, but what are the drawbacks of posterior PRP above C2? And what types of CCI does this have the most chance of helping? Yeah, Era, so there's a couple things to think about there and unpack. The first would be, as I just talked about with Jessica, that type 3A is the one that seems to be helped the most by this kind of thing, because those are the ligaments, the supraspinous, interspinous, nuchal, VDL ligaments, that prevent forward motion of 2 on 3. Now, having said that, even if there's higher instability at 0, 1, or 1, 2, patients can certainly get some temporary relief from precise injections of PRP into the 0, 1, or 1, 2 facet joints, which is what would happen if we were doing an X-ray guided injection with contrast confirmation and digital subtraction angiography. So more permanent relief if it's a type 3A, more temporary relief if it's one of the other types involving 0, 1, or 1, 2. Susie, regarding platelet dysfunction with POTS, people discuss in a group based on research from Dr. William Gunning. That's all I know, but hope it helps. Appreciate you. We'll look at it. Yeah, let's see. I think we talked about that briefly last time, if I recall. And I mean, I will look at a search, see if I can find anything. Okay, yeah, so a little bit different here. I have the paper. So thanks for giving me a little bit more info on that. Let me see if I can pick that paper up. Okay, so this is the paper, and it really talks about something completely different than I thought we were talking about. I'm just reading it now. Yes, I'm not sure this makes much difference with regard to how platelet-rich plasma would be used in POTS patients. What the study is kind of saying is that, like in many patients we have out there that have metabolic syndrome, meaning the average American who's overweight, high blood pressure, poor blood sugar control, there are elevated inflammatory cytokines or inflammatory chemicals in the plasma of and in the platelets of those patients, but doesn't, I mean, none of that has ever shown to be an issue with the use of PRP in patients who have known problems like that. So I would expect it wouldn't be in POTS either. So thanks for giving me more information on that. I think I can safely say after reviewing this abstract that this doesn't appear to be an issue in the use of PRP in POTS patients. So I wouldn't have any concerns after reading this of using PRP in POTS patients. Susie, regarding your patients who have POTS and who got upper cervical, let me stop my screen there. Regarding your patients who have POTS and who got upper cervical injection treatment, what is the percentage of this subset of patients for which POTS completely disappeared? Yeah, that's a good question, Susie. I'm just going to give you my personal best educated guess on that. I would say that we probably have had, it really follows the success rate of this procedure, which I've always quoted as around 7 in 10. So we have good results in those patients who have POTS and those POTS symptoms going away after we stabilize the upper cervical spine, but not 100%. Susie, is there one CCI measurement, CXA, Grubbox BAI, translational BAI in particular, which is pathological, a subset of CCI patients who also have POTS? No, I don't see any relationship between that at this point, meaning that I haven't seen any relationship between those specific measurements and a subset of patients who have POTS. Jessica, why does it seem my instability is only on the left and feels fine on the right? Jessica, that could be because we certainly see unilateral alar ligament injuries, meaning where we'll test the alar ligament on C1, C2 overhang and find that one side is fine and the other side is substantially loose. So could be related to that, or obviously some other unilateral, meaning one-sided ligament injury. That's just one example. It's been advanced by Chloe. Would having a fusion at C45 disqualify me for a PICL procedure for CCI? You know, Chloe, it certainly makes treating CCI patients much, much more difficult, meaning that any fusion leads to adjacent segment disease. That means more pressure going above the fusion and below the fusion. And if you have CCI in general, what we see that lower cervical fusions make the CCI worse because there's more forces then going up to that area. So that's a problem. And you know, that has to be looked at in the bigger picture for that patient, right? So you would want to make sure that we have looked at that C4-5 area and that is the only possible solution, and that it's highly likely that operating on that area is going to solve your problems before you actually get a fusion on that area. I would say probably about 80% of the patients who we see that do that get a fusion lower down 4, 5, 5, 6, 6, 7, for example. Really didn't need surgery at that level. They could have been helped without surgery, but that was never really fully investigated. Sophia, what percentage BMAC is stem cells? If you're talking about all stem cells in BMAC, it's a few percent. So that's usually what it comes out to be. That would be mesenchymal stem cells, all progenitor cells, CD3/4 positive hematopoietic cells. Jessica, I've had 2 neurosurgeons look at my upright MRI and say I have no instability, even though I feel like I can't hold up my head. I don't understand why this can't be diagnosed on these scans. Yeah, Jessica, as I always say, there's only about 5 spine surgeons in the world that do about 80% of these surgeries. So that would be Dr. Gillette in Europe. That would be in the United States. Dr. Henderson in Maryland, Dr. Patel in South Carolina, Dr. Frank in Florida, and Dr. Bolognese in New Jersey. So if you're not seeing one of those 5 neurosurgeons, it's going to be hard to get a diagnosis, because most neurosurgeons are going to approach this problem trying to compare it to the box of people who come into the ER after a severe car crash, for example, and whose head is falling off and they need emergency surgery. So if it doesn't fit in that box, they're just going to look at this and say there's nothing wrong. So if you wanted to get a surgical opinion, you would really need to see one of those 5 surgeons that do most of this surgery worldwide. Carrie, does the size of a person affect interpretation of these measurements? Yeah, Carrie, it's an important point. And meaning none of these measurements are hard absolutes. They do depend on the size of a person. Now, the good news is these measurements don't vary a lot, meaning if you're talking about the differences between the average size man and the average size woman, there's not a huge difference, for example, in the width of the dens. But if we're talking about the difference between very large men and very small women, there is a sizable difference. So we always have to be careful to be a little bit flexible on some of these measurements and try to put them together with the clinical picture to see if it all makes sense. Spin advanced by Maddie. How long, once we have a telemedicine done with you, is the wait to have a PICL procedure? Yeah, Maddie, that could vary, right? We have a lot of it depends on the time of the year. So usually a month or 2 or maybe 3. If patients are really having a hard time, we can put them on cancellation lists. And usually there's one person a week, one person every other week who cancels for this reason or that reason. And if you're flexible and can hop on a plane within a few days, then you can usually get in much more quickly into one of those cancellation slots. Stephanie, do you recommend a CTV inflection to determine if lung stylo is creating Eagle syndrome? No, simply because we've got really very little data on what should happen to the internal jugular vein in flexion on a CTV. Meaning, I think I've talked about this quite a bit now, and that is that the internal jugular vein and compression of the internal jugular vein is a common problem in patients without symptoms. So approximately 1 in 5 people have bilateral severe IJV stenosis and no symptoms. Approximately 1 in 3 people have moderate unilateral IJV compression and no symptoms. So I don't think we really need to be looking at what's happening positionally with the IJV inflection or extension, because we've got even less data on what's normal with that. Alexander, high Centeno, can basilar invagination be as a result of a type of CCI? Yes. So we'll often see that kind of problem, for example, in type 2A, where the dens is coming backwards into the brainstem. Chaos. Had my first PICL 2.5 weeks ago. How long should I wait to start taking my supplements again? You can take those right away. Yeah, not a problem. Charmaine, can orthobiologics treat cranial settling? Is ICT the only way to see changes in BDI to confirm the diagnosis? Depends on what we're talking about with cranial settling, Charmaine. If we're talking about movement or translational BDI, for example, then yes, we can reduce that movement. As far as invasive traction, I've always been a little cautious about the results of invasive traction because it's a test that is sensitive but poorly specific. And what I mean by that is that there's lots of things in the neck that if you offload them, people are going to feel better. So you could have a rip-roaring right C1, C2 facet problem that's causing headaches. You could have C2-3 involved that's causing dizziness, imbalance, all sorts of things. Pain right here, and then I give you some cervical traction and you feel great. Why? Because I've offloaded those facet joints. So if we use invasive cervical traction on a patient and they feel better, the question is why? Is it because we pulled that brainstem out of the foramen magnum? Is it because we treated that cranial settling? Is it because one of the facet joints was causing problems and we offloaded that? Is it because there was an upper spinal nerve that was causing problems and we offloaded that? That's the problem, is that it's super non-specific when we hear that someone got better or felt better. O'Brien, I'm in infant stages of looking into this possibility for my issues. How would I go about getting a DMX? I called the local bone and joint center in Albany and haven't heard of DMX. Yeah, so there's a national list of DMX places. You can contact my office, they've got it. And they will go ahead and get you that and show you where those places are that have that type of technology. Diana, thank you for your care, Dr. C. Sure, Diana, always happy to help. Amalia, in the sagittal view, the upright MRI and CT reveal mild subluxation of the right atlanto-occipital joint, indicating a mild subluxation of that side. However, the coronal view presents the atlanto-occipital joint perfectly aligned. What insights do you have on this matter with different views? Yeah, I mean, there's probably, so what you're describing is axial rotation. So what axial rotation means is that you've got C1 and C2 rotated a little bit. And if you look at it head on, you're not going to see much difference on the corners. But if you look at it on the side, you're going to see that C1 is ahead of C2 or vice versa. The question is, what does that mean, right? It may mean a lot if you're trying to readjust C1 and C2 as an upper cervical chiropractor, but it may have nothing to do with instability at all, because if you, for instance, got a little bit of scoliosis or side bend in the spine, rotation in the upper neck is very common with scoliosis. So what does that mean? It means that you're seeing some rotation in those bones. That may explain why some symptoms are happening, or it may not. That may be important for an upper cervical chiropractor to look at how best to get C1 and C2 back aligned, but probably doesn't mean a lot with regard to determining if you've got instability. James, how do you diagnose craniocervical syndrome? Doesn't show up in MRI, DMX, correct? Just based on symptoms. Symptoms and hands-on exam, James. I mean, one of the problems I think in the medical care system in general is that the value of hands-on exam has been markedly decreased through the years. And a lot of that is because we have all these fancy tests that we can do and evaluate. But there's really still no substitute for a good hands-on exam for a doctor, especially a doctor that does this work. So that means palpating every single facet joint in the neck, generally all 14 of them, 2 on each side, 7 levels. And to do that, you have to have the patient lying face up, have their neck relaxed. You've got to be able to have a lot of experience in finding those joints with some accuracy. Same thing with palpating all the nerve exit sites. Same thing with palpating or looking at, range of motion in various scenarios, or looking at how pushing range of motion in one direction or plane will increase symptoms or not. Or same thing with trying to support the lordosis and looking at on exam how that helps symptoms with certain movements. And a long list of other things like looking at specific upper cervical sensation, which is almost never looked at, or looking at nystagmus in the eyes with various maneuvers, etc. So hands-on exam is a key part of getting to craniocervical syndrome. Tasha, symptoms are warm, tingling sensations, head pressure, vertigo when I turn my head, can't lay on my neck or back, or look certain ways, upper arm or upper back burns, heart beat on my head, weakness, legs, and hyperreflexia. Yeah, so Tasha, again, all of that is interesting. We would need to do a telemedicine evaluation, have you fill out a 13-page form, look at your responses to all those different questions, look at all of your imaging, perform an interview to try to get to the bottom of whether or not this looks like it's craniocervical instability or not. Melinda, if a person has had a DMX diagnosis of cervical axial occipital ligament axia, the report and imaging enough to get a foot in the door to come see you, to see diagnosis, thoracicality, EDS, and POTS. Yeah, Melinda, so I look at each DMX myself. And I then make my own diagnosis after looking at the films. Now, the only thing I'll rely on the report on is the measurements. But in my experience, half the time those are wrong, meaning that we can find the correct measurements off the person's MRI DICOM file. And when we look at those measurements and compare them to what's on the DMX, I can then double check to make sure that those measurements are in fact correct on the DMX. So again, I think a DMX is great. I'd be happy to look at it personally. I don't trust DMX reports all that much. I find that they tend to be written more for medical legal purposes than actual medical diagnostic purposes. So I read all the DMXs myself, and then actually even double check the measurements on the DMX. But having a DMX is great. Something else to make sure you have would be a cervical MRI, because a DMX alone isn't enough in 2024. We need to make sure there's nothing crazy that we're missing that we shouldn't miss in this day and age. That's where an MRI becomes very helpful. Charmaine, with RA and often treated with NSAIDs, DMARDs, and biologics, are their least tissue damaging ones. I think you're asking well, I would need to know the drugs you're on, but when it comes to biologics with rheumatoid arthritis, the good news is I think biologics have moved the needle when it comes to patients showing progression of their disease. So that's fantastic. Now, that's a different conversation when we're talking about how those biologics might affect the use of orthobiologics, PRP, bone marrow concentrate, etc., and as to whether or not we can help somebody, in which case those biologics and other drugs like NSAIDs and DMARDs could become a problem in inhibiting our ability to treat. So I want to make sure that there's that distinction out there. Chaos, had posterior PRP in December and have been working on my curve since with Dr. Katz from Germany. I did a new scan 2 weeks ago. My instability and curve improved a bit already. Hope PICL will work that well too. Great. Zigzag, what CCI type is most likely to affect superior cervical sympathetic ganglion? It's going to be those that involve excessive rotation at C1, C2 or other movement at C1, C2. So that's going to be those 2As and 2Bs, or a 1C where you've got sliding of the skull against the atlas in that specific area, especially in flexion. It's been advanced by Maria Clark. Is there any anatomical connection between POTS and CCI? Of both, but POTS came first. Yeah, we believe the connection is likely mediated through the vagus nerve So there seems to be certainly a symptom connection, meaning I would say probably about 1/3 of the patients we see who get diagnosed with symptomatic CCI have POTS. So there seems to be a connection between those two. Now, realize that about 1/3 of the patients we're seeing for CCI also have hypermobile EDS, and we know there's a connection there. So is the connection directly in through CCI? Is the connection through hypermobile EDS? I don't think anyone's figured that out yet, but all great areas for research. Eli, what are the recommended non-invasive treatment paths for vagus decompression resulting from an acute atlas subluxation? No ligament damage suspected based on strength stability tests. I would say the first thing to do is to do more than strength and stability tests, and that would be to get things like digital motion X-ray, flexion extension MRI, to make sure there is no instability present, because that's going to be much, much more sensitive than hands-on strength and stability tests. As far as vagus, quote, decompression, there really isn't a need to decompress anything. You can treat the nerve directly, either under the sternocleidomastoid or actually even anterior at C1, C2. But I would really encourage you to get some actual testing beyond hands-on testing to see if there's craniocervical instability. Charmaine, people with RA often treated with those things. Yes, I think I got that one already. Jingesh, does having COVID-19 while travel after procedure affect effectiveness of PICL? I mean, COVID-19 right now, guys, near as I can tell, based on the existing and the current peer-reviewed published literature, is like having the flu. So there's nothing special about COVID-19 at this point. It has morphed into the flu, just like the 1918 pandemic morphed into the flu that we knew prior to COVID-19, meaning that all of those pandemics that involve respiratory viruses generally see the respiratory virus getting less and less virulent over time. Why is that? From an evolutionary standpoint, all viruses, if they can, mutate to spread themselves. That's what a virus does. So a virus that kills people very quickly doesn't spread real far. So they all mutate to become, there's evolutionary pressure for them to mutate to become less and less and less problematic, because that maximizes your opportunity as a virus to go from host to host. So that's what's happened with COVID-19. It's become the new flu. Just like the 1918 pandemic, the H1N1 became the flu that we knew before COVID-19. So no, I don't ascribe any special magical properties at this point in August of 2024 to COVID-19. Adina, is calcification of the anterior arch of the atlas, both superior and inferior aspect, a common sign of CCI and AAI? Yes and no. It depends on the age of the patient. If you see calcification in that area in a younger patient, I would submit that that's probably a good indicator that there has been instability there. If you see it, however, in an older patient, it's quite common when there's no instability. It's just normal wear and tear arthritis. Zigzag, what imaging can I get to help identify modifiers? Chiari, CMS, panisbursal fusion, facet fusion, facet OA. Yeah, I think the best thing to do is to obviously make sure you also have a good MRI, because many of those things can be picked up on a good MRI. If you wanted to maximize the chance of diagnosing any of those things, a good upright MRI with flexion and extension. And you got to be careful there, because you want to make sure that that upright MRI is high quality. What you're usually sacrificing in an upright MRI is quality of imaging. So you want to make sure that you're threading that needle so that you've got good image quality on the upright MRI, but you're getting the benefits of upright MRI, which would be the gravity loading effect. Chrissa, I'm having a hard time finding the recovery time on the website about how long after PICL or posterior injections can someone return to weightlifting and light cardio. Yeah, there's no specific time frame there. I think it's in the book. and it's certainly on the huge post-BICL instructions that we send to patients before the procedure. But basically, the goal is to thread the needle between soreness from the procedure itself and returning back to normal activities. So if your normal activities currently include weightlifting and light cardio, then you can return back to weightlifting and light cardio. Once the symptoms from the procedure itself, meaning the flare-up from the procedure, returns back to normal. Charmaine, can a giant atypical hemangioma, I think some of that was cut off, Charmaine, so I don't think I have a question in that one. Victoria, is BMAC effective in posterior injections that worth to add on top of the PRP? In my experience, usually it doesn't add a lot to posterior PRP. I think it's kind of a waste of money in most patients. Now, having said that, that doesn't mean there aren't some where we recommend it for specific reasons. But in most patients, I think it's a waste of money to add in bone marrow to a posterior PRP. Amalia, among the top 5 surgeons you mentioned, you missed Dr. Bartolome Oliver from Barcelona. Yeah, I don't know Dr. Oliver, haven't seen his work at all. Maybe he's working with Dr. Gillette, who's in Barcelona, but have not seen that surgeon come up on my list yet. So unless he's working in Gillette's practice, I would assume that as of yet, he's not seeing a huge percentage of these patients, because I don't know how many telemedicines I do a year for CCI patients. It's got to be 500, and I haven't seen that name come up yet. Charmaine, which ligaments are treated for cranial settling? What type of CCI is it? Cranial settling isn't a type of CCI unless there's movement. So that would be instability in a vertical direction. It's not one that we track because it would be lumped in with some of the other ones. So that being different than true cranial settling, where now realize that true cranial settling would be where the dens is pushing up into the brain. That's where the term comes from. The question, I think, would be in situations where you have a lower BDI, Bayesian Dens Index. Can you get a scenario where the Bayesian becomes so low that it starts to cause symptoms? And I think that's unknown at this point. But if it's occurring in our patient population, it's occurring because of laxity in some of those different ligaments that link back to different types of CCI. Kimmy, should SCM dysfunction start to clear up as the PICL goes to work? My left SCM is huge and the right almost does nothing. I'm set up to see an IPA PT in October, wondering if there's something we should start to get better on some ligament strengthening. You know, Kimmy, that's probably could be due to lots of different things, right? One could be that one side wasn't being used at all, and as better stability comes on, it'll get used, in which case they'll balance out. The other could be things like scoliosis, right? If you've got side bend in the spine, you're going to see rotation and side bend, so one SCM is going to get bigger than the other. So if it's due to instability, the answer is yes. If it's not due to instability, if it's due to things like scoliosis or forward head position and kyphosis, then it may not improve at all. Love Holly, is post-accident intermittent nystagmus a sign of CCI? Could be, it's possible. Melinda, sure. Tasha, do I need an updated MRI? Mine was done 4 months ago. Symptoms got a little worse. Probably not, Tasha. Charmaine, kind of thoracic, giant atypical hemangioma with involvement of the right posterior elements. There's a question in there someplace, Charmaine. I haven't seen it yet. Let me see if it's down here. T11 giant atypical hemangioma that involves posterior elements cause weakness and paresthesias in the legs. In general, hemangioma is not considered to be something that causes a mass effect that would lead to weakness in the legs. Again, I'd have to look at the MRI and see if this is an unusual scenario where we're getting some mass effect on those nerves in the spinal cord. Victoria, what are the expected results of frozen stem cells in Cayman for posterior injection versus standard posterior injection? Not sure what you mean by that one. So I'd need more information to answer that. Christian, hey Chris, do you need a new MRI or CT images before second PICL? Generally not, Christian. So I think we're probably good. I think I answered that one. John, how common is death from a C1, C2 fusion? Yeah, it's a good question. I don't know the answer to that one. I would say that the mortality rate from upper cervical fusion is not zero for sure. Just like the mortality rate from any cervical fusion is not zero. I've never seen it reported in a very large case series of upper cervical fusion, probably because very large case series of upper cervical fusions don't really exist. And it's the reason why if I were to get upper cervical surgery myself or send a patient for upper cervical surgery, I would limit that referral to one of those 5 surgeons I mentioned or anyone else that presents themselves of doing high case volumes, right? You want whatever surgeon is doing surgery in this area to have done it hundreds of times a year for many, many years. So that they've got many thousands of cases under their belt, because the mortality rate or severe complication rate of any procedure goes down as the experience goes up. It's one of the reasons why I would never get an upper cervical fusion from someone who's only done 20 in their entire career and maybe does one once every couple of years when someone comes to the ER where their head's falling off. So I think that those are all things to consider. John, does movement improve stem cell healing? I would say this, that trying to thread that needle, as I talked about, between doing your normal activities and not causing a flare-up or having a flare-up is the thing that probably maximizes healing, because you got to realize healing is in part related to loading of the tissue, to teach that tissue what's necessary with regard to the load it's going to have to bear. Okay, guys, I think that's the last question. We are about 5 minutes over. So I want to thank everyone for, again, great questions, again, great participation. I think these Sunday slots maybe give us 20-25% more participation than we usually get. So that's wonderful. If you get a chance, like this wherever you are, whether you're on YouTube or Facebook, because that's how the algorithm gets this information out to more patients. And again, the goal with these shows is to try to learn as much as we can. And we all learn by asking questions and getting those questions answered. Let's see, one more question here. Is it possible to have DMX overhang value in the lower range if DMX is done in the early stage due to severe acute inflammation, not allowing enough overhang? Yeah, I think DMX overhang values can be affected by lots of things, usually not inflammation, but certainly range of motion. Holly, thank you. Charmaine, thank you. Stephen, thank you. Renee, thank you. Thank you, guys. Again, make sure you like this so that people can find this video and understand what's going on with these things. I'll be here next weekend on Sunday with another topic, and you all have a wonderful week out there and stay safe.